as well.
Thank you, Lisa. And thank you for everyone joining us online. We are going to go ahead and get started. And I have the privilege of introducing our speaker for tonight. Dr. Mark David Lim is the Director of Global Public Health Programs at American Society of Microbiology, our home base, leading a division of leverages and expertise of the ASM community to strengthen laboratory services and lower resource public health systems. Prior to joining ASM, Mark was a program officer at the Bill and Melinda Gates Foundation, developing diagnostics for cervical cancer screening and neglected tropical diseases. His career also includes a think tank focused on rare disease patient philanthropies funding medical research, chief of technical staff for the diagnostics and vaccine innovation programs in the Department of Defense DARPA, and program director for a funding program at the National Cancer Institute focused on innovative technology development for cancer, or IMET. Mark earned his PhD in inorganic chemistry at the University of California, Santa Barbara, completing a postdoctoral nanotechnology fellowship at University of California, San Francisco. And he's also served as a AAAS Science and Technology Policy Fellow at National Cancer Institute. He has published 32 articles and book chapters focused on global health diagnostics, mechanisms of private and public partnerships, and biospecimen quality, in addition to fundamental research articles on nanotechnology and inorganic photochemistry. Please join me in welcoming Dr. Mark Lim.
So, well, I normally sit in the back, and it's because, as you get heard, from my bio, One Health is something I'm still learning, and this has been an opportunity for us where we're so happy that we just have to go downstairs and we have all these One Health experts coming and they bring snacks, and it's been great to sit in the back, but it's also been an opportunity to meet a lot of you, and some of us have formed some really nice friendships. I think for us as a society, our focus is on microbiology, and I'll go a little bit more into it. But to understand really the applications and the social impact that we could push the society and our members towards is something that we strive, and I'll provide a little more context. So really quick, because I'm still learning, I have a lot of questions throughout this. If there's something that's meant to be, confrontational, it's not meant to be. It's more open questions, and more importantly, I'm just still learning. Have a lot of questions. You'll see it spread throughout the talk. Blair has constantly told me I could use this as a place to. And one last disclaimer, my lens and focus has been on lower resource settings. So when I do talk about One Health, I know it's not just limited to lower resource settings, and it feels like if I'm missing a lot of what else is happening domestically, that's definitely not intentional. It's actually probably just not in my focal area, but I think there's a lot of ways we can look at it more kind of globally. A little bit about the American Society for Microbiology, the building that you're sitting in right now. It is one of the largest life science focused societies. It's founded in 1899. You're sitting right in our headquarters here in DC, and our community is about 30,000 members across 26 different disciplines of microbiology. If you asked me to mention every discipline, I wouldn't be able to do it, but it is quite a large community that ASM continues to nurture and grow, and really it's not just nurturing and growing, but really trying to advance the field as much as we can, and that's been kind of in our blood since the early 1900s. We host a lot of multidisciplinary meetings. We have a large kind of microbe conference that brings together all of them, kind of these large conferences, but we also have a lot of specialized conferences as well that are very topical. And then we also work to deploy resources and expertise around the world through our programs. We also do it through our textbooks. We have educational programs, in addition to meetings. We have professional development. We manage certifications and accreditations. And we also have a book that's a couple different things out of our press department, including this one that's focused on One Health. And of course, we have a policy and advocacy department that's, being here based in Washington, D.C., where we continue to push and make sure that we advocate for both sides as well as microbiology. A little bit about our team, the Global Public Health teams. We've been on since about 2005. And really the focus was where within global health, there was a need for expertise in laboratories and microbiology. And groups, particularly the US CDC, came to ASM, said, how do we design programs? How would we strengthen labs? And this is under the context of when PEPFAR was starting. And really kind of us as a community of microbiologists were able to bring together our community, help create curricula, training, and program know-how. And then basically they said, well, why doesn't ASM kind of start running these programs? And that was kind of the birth of our programs, kind of starting in PEPFAR, growing through global health security agenda. You know, we do everything from kind of training, curriculum, workshop. I'll go a little bit more into detail about it. Probably one of our strong strengths is really kind of a mentorship based. You know, there's global health has a lot of kind of going in, doing workshops, going out, coming back to a whole different workforce, doing another workshop. But really for us, it's really connecting microbiologists. And that's kind of core to what we do and part of our mission. We also do kind of bread and butter systems looking and try to do actual facility and systems improvement, both in clinical and veterinary laboratories. Biosafety, biosecurity, infection prevention control are obviously core to microbiology. And we have some nascent programs, which Catherine's leading, really looking at farm security, some others looking at livestock vaccinations and kind of animal husbandry. I'll share kind of a portfolio of what we do. Our secret weapon here is microbiologists. It's both our strength and our limitation, I would say. That's kind of our focus. If you ask us to go into kind of really community health, that's probably not the area we're in. We're really kind of focused in the lab, but at the same time, that is actually calling for a need for partnership because, and I'll share why we think that's important. Our goal is to strengthen the microbiology capacity in these countries, and we're out. So ASM, very much, we work as much as we can with local organizations. African Society for Laboratory Medicine is one that we're very close with. Africa CDC, on the middle picture, that's the Pakistan National Institutes of Health. And really, by strengthening those organizations and the capacity, we leave something behind, which is kind of knowledge and know-how. But we also learn a lot as well that we can go back to our kind of broader global community and kind of really look at those problems that are really microbiology focused and try to see if there's a way that we can provide an answer. We also work very closely with in-country microbiologists. That's all, again, core to our mission to strengthen global microbiology, strengthen microbiology capacity globally. And also just so kind of it, we try to develop resources and really be looking from a cost effectiveness kind of sustainability standpoint. This is kind of a snapshot of our program and then the people who are behind it. Stefano, as you can see, is right. He really lives in this building. To the most right is our director of communications, and the rest is kind of our global public health team. Some of them you can see in the back. There's 3 individuals that are in there that are kind of our secret weapon, which are microbiologists from the ASM community. I don't know the best way, but there's 3 individuals. One's Dr. Elizabeth Thomas, one's Dr. Doug Abbott, and also Martin Evans. These 3 folks here. And those are the folks that help us create these curricula. They're the brains behind the brawn. In fact, Dr. Doug Abbott, the reason the 3 of them were here was they were here to kind of think about how we do our training. They spent 2 days locked up in a room, coming up with training curricula for some of the programs we do in Ethiopia. And the certificate that Doug has is a 50-year. He celebrated his 50th year as an ASM member. So it's really the passion is amazing from this community. Just some pictures of them in the field. The top is Doug Abbott in Ethiopia at the Ethiopian Public Health Institute doing a training. And the bottom is Dr. Martin Evans, who is at one of our hospitals in Ethiopia, Tash, who has a very small microbiology lab and also doing a lot of the training there. So they are definitely the folks that are the face of our programs. We work very closely with other microbiologists, and here's just kind of a quick snapshot across different countries that we work in. And this is our extended family and those who we work with and really try to both empower as well as kind of do kind of a lot of knowledge exchange as well as tools. And they're very important to why we're able to do what we do. So, you know, the focus is One Health, and this is where I'm going to start adding. Now I'm going to go into an area where I don't know much. So I focus on this a lot. It's something that when we had CDC here as well, kind of this definition that One Health recognizes the health of people and its interconnectedness with both animals and environment. Really, and the focus, which I've bolded, is achieving optimal health outcomes. And that to me is at least kind of the guiding star. And you can kind of see a generic look at it. So we're ASM, we focus on the microbiology. You know, for us, how does microbiology play a role in this whole kind of One Health thing? And this is where I'm starting to kind of figure out where can ASM and our community make a broader impact. You know, there's kind of a common phrase, it's microbes know no borders. You know, we take that very literally. When I talked to Dennis Carroll when he was here exactly a year ago, I was asking the same question I asked all of you, like, what can we do at ASM? And he said, ASM, just follow the damn bug. And that's what but it still kind of resonates, like both his voice as well as kind of the thought that it is like, he's like, it doesn't matter the species, it's the bug we have to focus on. So just to kind of to make sure we're all on the same page, microbes, it's not just bacteria, it's viruses, fungi, protozoa, elements. And then the way I'm starting to frame it, which I'll walk you through for both kind of discussion that I would, is they could either be how we see them sometimes as pathogens. They're somehow related to some kind of infectious disease, and I'll dive a little bit deeper into it. And one thing that I've started thinking about is, can they also be a sentinel? And I'll describe a little bit what I'm kind of thinking about that. So kind of microbes in One Health. Again, this is just my own kind of perspective and kind of sharing what I've learned. You know, it's really focused on the interconnection between people, animals, plants, and the shared environment. To make it easier for me to think about things, I kind of separate in two different buckets. One is direct, where microbes are the focus. And for us, that's some of our programmings in antimicrobial resistance. I'll dive a little bit deeper into that, as well as zoonosis, spillover between species. And there, the microbes really the focus of those efforts, and that's where the One Health. There's other areas where I'm wondering, you know, can microbes also be an indicator of what's happening within a One Health context? So I'll walk you kind of through this little kind of cute scenario that has helped me kind of think about it, but has also probably confused me a little bit. So indirectly, you know, are microbes an indicator for what's happening in food security, for migration, what else is happening, climate change in the world? Where it might not be the direct kind of impact, but is it something that we could actually measure? Because if you can't measure it, you can't fix it. So is it one measurements to understand what's happening in the world and this interconnectedness? So here's just kind of an example, completely hypothetical, but there is some interesting things that I've been reading about. You know, we've seen this in this data from FAO, you know, where, you know, as we've seen increased kind of meat consumption around the globe, you know, both geographically as well as in number, and you can see again, it's actually a really nice website. So as we look at kind of increasing the meat consumption, kind of what's the other impact? Now, I think directly to humans, you know, antimicrobial resistance becomes an immediate kind of, oh, well, AMR is probably becoming a broader issue. But then what's happening actually, you know, as the animal consumption, as meat consumption goes up in terms of the food that we grow to feed the animals, and what's the impact of that on the wildlife? And what's the impact of all of this happening on the environment? And there's an interesting kind of little snippet I saw out of the American Geophysical Union meeting, where it's just kind of fascinating, but I don't really know what to do with it. Where in China, and again, I'm just reading off of kind of an abstract that I read, what they had seen is they had seen increased meat consumption, and it's kind of a study, and they're able to connect it to increase in newborn deaths. You think, well, I kind of see that, but the way that they were able to report it, again, just off of this little paragraph that I read, and is that they actually contributed to increases in crops for feeding animals. And then because of that, there was over-fertilization and an increase of nitrates in the water, which were getting aerosolized, and now they're more particulates, and that was causing what they were able to connect it to. And to me, I was like, whoa, this is something that I would have never even thought about in terms of causality and connecting the dots. And it kind of goes back to the question is, if we just looked at it now as an indirect, could the microbiology have actually also made those connections as well if we were able to kind of look at it? So kind of going back to a kind of direct impact to human health, you know, there's AMR. That's an area that to me is very simple. It's very easy, even though it's quite complex still. To me, the relationship is at least a little bit more linear. You know, over misuse of antibiotics just to treat our own human infections. Thank God for them, because, you know, many of us wouldn't be around if it wasn't for antibiotics. But now we're having problems with misuse and overuse. You know, farm industrialization. You know, direct consumption of those animals, you know, who have you know, kind of AMR bacteria that are zoonotic in potential and being transferred to humans. Environmental exposure, to me, those are like directly, those impact human health in a very linear way, as well as kind of zoonoses and spillover. Indirect one is what happens, can we use microbiology to understand what's the impact from a One Health perspective, on reduced forest coverage, what's happening there, find food security, as we know about it should be the African swine fever, human-animal migration patterns, climate change. Does microbiology actually tell us a different story of what's happening and present us not as a tool of just measuring it, but maybe a way to solve what's happening? I don't know. I don't have any evidence. It's just kind of some ideas, as I've been kind of noodling on it. With AMR, again, kind of going back to this, will kind of underpin some of our programs that I'll describe. And I think this was data that Dennis Carroll shared with me. It's about 63 tons of antibiotics. In 2010, 50 to 80% of it was for antibiotic use, and they're expecting it to increase by 67% by 2030. Poultry is the primary consumer of antibiotics, and swine, and then dairy. The main challenge is that they're unregulated in many countries, and in fact, in many of the countries that we've been to, they're called food savers, antibiotic growth promoters, performance enhancers. And if you bring it down to like, are you going to take this away from a farmer? What does that actually cause? Like, where's the intervention there? It's a very different kind of, and I'll go a little bit more into it. So you can kind of see, at least from this snapshot tip from this article, just like all the different contributors from a One Health perspective of the spread of antibiotic resistance. For AMR surveillance programs, the antimicrobial susceptibility test is our workhorse. At its basics, and what we have worked with a lot of deploying in our programs is just the basic culture, even though there's better technologies out there. And basically, I wanted to show this as kind of a scheme. This is actually a program that we're working with in Tanzania, where we're trying to work both with the government at the ministry level as well as at the facility levels to make sure that this can happen. This is kind of the dream as shared in their national action plan. This is on the human side, where you can get the specimen, you get the laboratory data from this AST, and you get a patient report that a clinician can act on. If you start rolling up this data as you go down, it eventually goes into a larger database. For WHO, for human health, it's a database called GLASS. And then at that point, you're able to monitor what's happening from a human health AMR standpoint. They have an equivalent one called WHONet that we're also working with kind of on the animal health side. I don't have a picture of it. But in addition to AMR, the Microbiology Lab plays a very critical role in a lot of public health preparedness and effectiveness. This is an article I was kind of surprised is written 12 years ago, but it still resonates with what we know with a lot of these kind of emerging and re-emerging diseases, where you can see a lot of the causal contributing factors on the right, which have a One Health kind of aspect to it. I don't want to force it, but there's a lot. But at the end, infectious agents is a microbe that's there. So there's a lot of interest, obviously, in the Microbiology Lab playing a role in terms of public health preparedness and also the effectiveness of their response. So kind of going back to now some of the questions is, what are we implementing One Health for? And this is something that I can see the AMR side, I can see the zoonotic side. And I feel like there's always kind of two different mentalities. One is, if we build it, they'll come, or will they come? Or you start with the end in mind, try to figure out what you're trying to build for and go back. And I take it from my background with diagnostic product development, where in the commercial space, 70% of these diagnostic prototypes never get adopted. They die. They don't meet clinical need. And there's a couple of different reasons why, at least hypothetically, is that a lot of these technologies are focused on the technology itself and how shiny it looks, and just they can generate a lot of data. And a lot of the times that's good for research use, but not actually like a clinical use where you're trying to do an action off of it. It just generates a lot of knowledge. And you'll see why I'm trying to parallel this to where I'm seeing One Health. So very few, and these end up being the more successful ones, and takes a lot of work, is to find, like, how is the data going to be used to actually inform some kind of treatment decision? Are you looking for a patient? Are you looking to see if the patient responds to disease? Are they cured? And there's a lot of kind of that contextual kind of use cases. And you also have to define like how the users are going to create that data. You have to understand the workflow of how that data kind of feeds into it. Kind of general observation from kind of implementing One Health programs is that there's definitely an appreciation, and there's a lot of evidence for interconnectedness between kind of the trifecta of One Health. And there's a lot of efforts which are definitely important for improving the collection of reliable data. It's a garbage in, garbage out mentality. And if you don't have the capability to generate quality data, it's not reliable. But where I'm struggling with is, and maybe I'm just trying to look at like, how is One Health actually implemented? Like, what's the problem we're trying to solve? And that's where I'm struggling. Again, these are just questions. And then all this data that we're collecting, including many of our programs, like, what's the actual intervention there? Especially when you start integrating all these programs. Microbiology is only one component of it. You do animal health, veterinary, and human health. Like, how does this data come together, and what is someone going to do with all that data? And I feel like sometimes we're just creating a lot of data, but first you kind of ask, like, why is the data going to be useful, and kind of go backwards. And sometimes I feel kind of an internal conflict with that. So in the diagnostic sector, we start with defining the market, and this is very important. It's kind of the first stage for most diagnostic product development projects. It has nothing to do with the technology. It's purely on the use. So you have to figure out what the problem is, what you can do to solve the problem, and then you got to figure out what's the data that's going to tell you how to solve that problem and how you act on it. And then also, more importantly, is how are you going to sustain this test? Like, what's the cost point? How are you doing it? And you can see kind of these are common points for why a lot of diagnostic products fail. I kind of feel like we could do something similar with One Health, and maybe it's already here, and then I just haven't seen it, or no one's that. Like, what is that definition? Like, what are we trying to solve when we look at One Health? Can we start from there? Start from the end. Understand where data can inform an intervention. So we have to figure out, like, what is that intervention when we start mixing all this data? And then how is this market sustained? I mean, there's a big rush into One Health, but who's going to end up kind of keeping all of this data kind of coming together? Who's going to maintain it? And those are questions I'm still kind of struggling with. The last point is actually important to me that I've been also trying to figure out is, like, how are patients, farmers, environmental researchers incentivized to actually participate in the benefit? And I'll kind of show another cute example of, so for the work that we do, in order to get improved health outcomes, in order to improve someone's health outcome, you're going to somehow intervene. In order to intervene, at least for a laboratory and for laboratory data, you have to have some kind of data, some kind of test result, so that you can act on. In order for that data to be reliable, you have to make sure that your laboratory has quality processes in place. So for one good example is a recent paper that came out where they're using next generation sequencing. They sent it around bacterial isolates to all these different labs, and they got different results. And their conclusion was, if they used that test result to guide treatment, there would have been different antibiotics administered. So to us, that's a quality issue. And that's what here at ASM we see as kind of the common nut that we need to kind of figure out and make sure that we can at least guarantee the quality of the test result. Again, that's kind of just a bunch of bullet points of the way we frame things. We frame it in a couple of different areas. We work a lot with governments to help develop guidelines and policies, because sometimes that rolls down to the facility and how people do work and SOPs. And we have a couple of examples of working with national governments, Ethiopia, Mozambique, Tanzania is ones where we've actually helped them set up both national action plans, surveillance plans, as well as specimen referral networks and biosafety plans. We look at the laboratory system. The laboratory doesn't operate in isolation without getting specimens in, as well as commodities in, and we want to make sure that those are reliable as well. We have lots of examples of those types of programs. Look at the facility level. Are the equipment being maintained? Are they working? Do they have running water? And Anna will tell you about all the places that don't have running water as the key components. And more importantly, it's the people. I'm not going to go through it, but it's all within this framework. We kind of cutely call it our Peacock diagram. But it is all kind of within each component has a lot of depth to it. But we think all together, it's really needed first kind of as one benchmark, getting a lab accredited to do clinical microbiology. But the laboratory needs to be in context of both what's happening in health system strengthening, local capacity. And our intent is, in the end, we hope for better patient outcomes. But a lot of stuff happens outside the lab. And there's going to be a parallel here that if a clinician doesn't even care about a test result or a test, they'll never prescribe it. So we can't just function in that lab in the dark area. We have to also understand what's happening outside. And this is where we're looking for partners to help us understand the space. There's also a parallel that I'll put in. So a clinician has to even ask for a test result. And then you have to have a patient who will say, okay, I'll give you some of my specimen. and I'll trust whatever comes out of that. And if you don't have both sides in that loop, the test will never be used effectively. It'll have no impact on that person's health. This is something, it's still kind of a conundrum, and even here in the US, in terms of the use of diagnostic test results, it's definitely a challenge when you start going to lower resource settings. I think it's going to be a big challenge when you start looking at animal health, because animal health has a very different incentive. It's not necessarily public health when you especially go into a rural farm shareholder. So first, it's obviously a program typically. So it's a One Health program, has to decide, okay, there's a decision that we need to collect animal data. And the shareholder has to trust that you're not going to go there and you're going to collect their and swab their chickens, and you're not going to go back and cull all their chickens. And there's a very different driver for me, at least very simplistically, as I've been kind of poking around and trying to figure this out. Like, how do you shift that their own family sustainability, or how do you connect it with that incentive to participate in these kind of larger programs? So, you know, kind of in the first category, then somehow you have to integrate all the data, not just the microbiology data, but also everything else, epidemiological data. And that program manager now has to make a decision. And they're going to come back to the farm and inform that farmer of what the test results were and probably act on it. And I can't imagine it's very different if it's a clinician or community health worker saying, have your test result. I hypothesize that it'll be a very different reaction when the laboratory comes back to the farmer and say, hey, have your test result. And I think this is an opportunity for us to understand from the anthropological side, like how do you actually do this? Because it's an incentive structure. Again, this is outside the microbiology scope, but I feel like unless you address this and complement it to the microbiology, we're just focused on the lab. But for the implementation side, you really have to focus on these other aspects that's very similar that I've seen on the clinical side. So we do some work going kind of lower down into, and this is some of the work that Catherine's actually leading, as well as some members of our team, where we go into the animal health laboratories. Again, we take a lot of the same models that we do in the human health labs to the animal health labs, workforce training, rehabilitation, biosafety, prevention, control. And you can see on the two left side, those are veterinary health staff. On the right side, it's going more into the community level. The one in Iraq, that's for the Crimean Congo hemorrhagic fever. And again, it's work done in collaboration with a partner known as Livestock International. Corey Brown was here a couple months ago, as well as some stuff with avian influenza in Egypt. I'm not going to give any justice to it. Catherine's been the workhorse behind it, but this is stuff that we're also going where these are really distributed at the butcher level, abattoir level, and really those who are working and are working with the carcasses as well as with the meat production itself. Kind of going back to the challenge that I see is, this is an article, thing that I'd stolen from a presentation by Juan Lubroth from FAO, is that in Africa, as one example, most of the food goes straight to the consumer. And many of us who've been in this space, you go into these markets, to see animals kind of hanging. So where do you actually intervene and actually do these measurements? On the right, this is a study done in Nigeria looking at the food supply and looking at kind of the different routes. And there's still, in Nairobi, direct farm to consumer. So where does One Health intervene? And then also, how about the 30 to 50 million kind of nomadic pastoralists? And I feel like there's a need to kind of understand this. Hopefully I'm not being a wet blanket. These are just questions that keep on popping in my head. And I feel like I just buzzkilled everybody for. So a couple observations from the field is, there's a lot of build it and they will come mentality. And I think it's an easy thing to do where you generate data, and you integrate data, but like what's the decision behind it? And I see a lot of this in public health disease surveillance, both AMR oriented and others. I see a challenge with resource allocation. I think this may be obvious where there's a lot of funding going to clinical microbiology labs. They still need a lot more money, but then we go and do our needs assessment of animal health labs. And we're like, ooh, these are in bad shape. There's gonna be a lot of work that's gonna be needed here. And then we go to the environmental health labs and they're like, well, we borrow space from the clinical space when there's an outbreak. Sometimes we find something here and I feel like, wait, how is this gonna happen unless really, we start like also resourcing these labs, because you're losing the capacity to do it. And otherwise you're just constantly in outbreak response, which is not sustainable. And that's just one intent of One Health is outbreak response. So another thing that we've also seen, particularly in one study that we did in Ethiopia, is there's no coverage of animal health services, not even community animal workers. So how do we how do we integrate these programs when they've never even seen a veterinary or any kind of animal health services? So how do we encourage this? Because this can't be internationally. This has to be like, how do we prioritize this into the national budgets so that they actually prioritize both environmental health and animal health? Another challenge that I see is, this changing of language from growth promoters to antibiotics. And we know in one country that we were visiting that broilers won't even accept the chickens unless they had growth promoters in them. And that's going to be a challenge for many as it distills down. And that language is not, it's going to be a barrier when it comes to working all the way down to the farmer or the animal health farmer. So kind of going back, I won't go back into it, like, can we define this market and the challenges? And if it's there, I would love it. That would, it would be really helpful to understand, or can we start bringing people together? Because I think once you understand that pathway, then everything kind of falls in place in terms of the data and how we actually intervene. Many thanks to everybody. So obviously ASM's been, microbial sciences is a very important part of our community. We work very closely with country collaborators, both the microbiologists as well as with governments. Implementing partners, particularly in the One Health side. I mean, Blair's been generous enough to let me, and Tanya, let me, ask these questions that and hopefully are naive, and hopefully there's an answer behind it. The One Health Commission, obviously, I've been talking to Cheryl a lot. EPA, this because we even headed over there to help kind of discuss a couple of different things. Our consultants, as we had shared, both international and country, and a lot of this work is done by our funders, which includes the CDC, the Fleming Fund, Department of State, and the Henry Jackson Foundation for Military Medicine. So thanks a lot for letting me ask a lot more questions and putting it on a slide deck.
All right, I'm on the mic. Thank you, Mark, for the amazing talk. As we do at the One Health Academy, for those that are new, we like to give to our speakers a flag that has been flown over the Capitol. So I know you're well aware of that, Mark. Thank you very much for all of your amazing presentation. We're going to go through and ask a few questions. We've got a good amount of time, so I'm going to pass the mic around, and then Mark, I'll just ask for you to repeat the question for those on the computer. So any questions from you?
When you do work in a country that has both clinical laboratory and animal laboratory, does any of your work sort of focus on getting those two to communicate when there is a finding of interest, and what sort of barriers have you found to that sort of open communication pathway?
We haven't hit any direct barriers, but we can envision it. So we do work with connecting the data probably at the higher level. They're not at the facility level, they're not communicating, but it's more aggregated data. And some of the countries that we work in, it really kind of comes to a coordination committee, and that's what we try to work. So they get both the animal health data, and then there's the human health data, and there's a national, for this one, it's an AMR data coordinator that kind of puts the data together. And then they decide on behalf of the government to upload the data into something like WHO GLASS. In terms of communications, it's really interesting. We had actually a team just this morning of environmental microbiologists from the US CDC, and just talking about waterborne illness and waterborne food. The jurisdiction is an understanding, is this a Minister of Water or a Minister of Health problem? Ends up being such an interesting, and it, even for them to understand, and we were talking in context of cholera, who does what in the midst of an outbreak, and even that map is not very well known. So I think in a lot of they're not communicating because there's really no guidance. Some of the work that we've been exploring is actually kind of at the policy level of setting up some kind of governance to make sure that there's a final decision maker, but also the data is going and someone's going to finally act on behalf of the government. But right now in a lot of these areas, unless it's kind of formalized in like a national action plan, I think it's very hard. You really need the top-down kind of mandate in terms of a policy. I hope I answered that. Yeah.
Yeah. I don't know, just small enough room so I can talk with you. So, Billy, first of all, on the question that you were asking, Mark is familiar with an example that is going to be tried with the African CDC in Zambia, in which Zambia has been chosen as a kind of one health innovation country by the African CDC. And one of the innovations that is expected, it will take time, is the construction of a BSL-3 laboratory that has one leg that is human, one leg that is animal, and in between a chance for those two bodies to interact and exchange views and also have outreach into the other countries, because it serves as a regional coordinating center for South Africa. But again, it's also a question, it seems to me, of success moving to success and finding a country in which they have all the right buzzwords and then move from buzzwords to action and to implementation. Now, I do have a question for Mark. This reflects my ignorance. But in the health sector, what was a major issue that was a challenge and an argument had to do with task sharing, used to be known as task shifting. It meant that nurses would take on activities that doctors would take on because the doctors just weren't around in many of these low resource settings. And I don't know enough about microbiology, but I wondered whether there are assistant microbiologists or microbiologist practitioners who essentially are not at the master's or upper graduate level capability that can serve to do several things. One is to do the analysis or use the analysis, and B, then take the message and spread the word of the importance of the subject to a whole host of things. And my last point before the question is that I was involved in the last century with regard to the success of the effort of micronutrients in nutrition. And the point is that they identified a target that really resonated, and that was under 5, the 1,000 days between pregnancy and essentially fully developed. If microbiology could find a target that it could very clearly and sharply define, that would help finance ministers say, yeah, this is what we got to do because there's all these other players that need to respond. So look, that's both my overlong comment, but also my question.
Yeah, so I think kind of the first question is, and if I could, is kind of the role of the microbiologist to communicate within a broader system about the need, and then maybe it's connected still with even the second question, Dick, if I'm kind of paraphrasing it correctly. I mean, I think one challenge, which unfortunately is just human nature, is many times what we find, and I'm thinking, and Anna knows this very well, is that even the laboratory is, and this is also in the US, the laboratory and sometimes is not integrated within the larger health system. So we found, and this is something that ASM recently convened something called Clinical Microopen, which is US focused. And I was kind of shocked leaving that, saying that in a lot of the AMR committees at the hospital level, the laboratorian's not part of that. And I was like, wait, well, what's going on? So you can imagine when you start going, in some, including some of our settings, we've found outbreaks in some hospitals. One was specifically, and I want in a respirator at the NICU, if that's, and we tried to alert the clinicians that this was happening. This is some of our ASM microbiologists discovering it, that this kind of a rare, unexpected outbreak was happening. And really the clinicians really, it was ethically, we continued to try to push it. But sometimes there's a social cultural part that's hard to get the, it's just kind of sometimes human nature. And I think that's where the anthropological, like, how can we look at this, incentivize both top down, whether it's a ministerial level, to understand the role of this one, if it's a one microbe or one particular, how can we get them to understand the public health impact, the economic impact? Like maybe do we have to talk in their language? And is that our role as a community of microbiologists, or do we have to work with others to figure out how does a microbiologist speak in finance or on national security? And is that kind of a role that we should play as a society? But also, how do you start breaking down these kind of institutional barriers, clinic versus lab versus, and I don't know, clinical versus veterinary, I don't know what the cultural differences are there. I can only imagine what they are. Environmental, Tanya, I don't know what but how do we actually start getting them to truly work together at that level? and understand that we're all trying to contribute to a greater good. I'm not really providing an answer, but more just kind of sharing kind of a perspective.
Sorry, I'm soft-spoken. When we were in Ethiopia in November, one of the, I think it was the director of NAUTIC, and I've forgotten his name, so forgive me, but he talked about the fact that in a lot of nomadic tribes that farm small ruminants, which is like goats and sheep and all sorts of stuff like that, there was a tradition of if an animal died, you burn it, because anything that ate that animal would then die. So there does seem to be sort of old knowledge that's kind of gone through the generations in some of these nomadic traditional farming cultures, like in Ethiopia, about how to deal with some really bad pathogens. In this case, we're talking about anthrax, which they did actually finally isolate and grow there at NAUTIC. So, I think that there's actually a little bit more research to be done actually with some of these communities that these particularly bad pathogens affect, so that you could kind of figure out how to speak their language and make sure maybe you're getting information from them at certain points. So I found that fascinating.
Yeah.
Questions?
So you brought up wanting to kind of switch the model from like gather data and eventually your path forward will be revealed to starting with the endpoint in mind, which I think is a great idea. But do you have do you have anything in mind that you can see as like that marker to put down and say that this is a goal we can work towards? How can we, or do you have examples of something you would like to work towards?
I mean, it's not even, we don't even have to categorize it as One Health, but even in the AMR space, I'm still not that sure what, like at the clinical level, at the patient level, I understand exactly what we're trying to do is make sure that patient doesn't take the antibiotic in which the resistance and promote. That to me is very clear. When we start doing surveillance, like what is the action when you start seeing these hotspots come up? Who acts and who does what, and how do you verify and how do you make sure that that you've kind of quenched maybe the spread of AMR or stop the transmission of AMR? And I feel like AMR is so broad that, do we think about it in terms, if you look at it TB versus another one, they're very different use cases. And I think the devil's in the detail, but I think we're scared of going down that deal because it's a lot of work. When we start going to the animal health side, that's where I go, whoa, now what happens when you start mixing, again, hypothetical being very oversimplistic, but say we go out into farms and we find that 3 of the chickens out of 6 or 10 are resistant in one farm. What's the action? That makes sense from a cost effectiveness. So like if you're in Nairobi and something's happening out in Kisumu and you're seeing that there's some chickens out there, do you actually send out armies of folks down there and try to do you even call all those chickens? I don't understand. That's the part that I feel like needs a little bit more context, and it's quite difficult. We had done that at the Gates Foundation. We're looking at some of the neglected tropical diseases, and it took us about 2 years just to come up with use cases that the community agreed upon. So it can be quite contentious, and people have their own kind of niche way of doing things. But if you have these battling forces, you just never get any, and everyone else just doesn't have those guidelines to understand. And I feel like being able to put it all together from a public health cost effectiveness, like if a Ministry of Health was truly to manage their own One Health program in a low resource country, how would they act, and what's the data where they would actually spend more resources to intervene? And I think that's important, but I think I get scared thinking about that, and I'm sure a lot of other people are like, well, that's a lot of work, and who's going to do that? So I don't know, it's quite challenging, but I think it's needed, because otherwise we'll just continue to collect stamps.
I worked several years in Colombia, and classically, every year, humans get Venezuelan equine encephalitis, and they are in effect the sentinels for the disease, which when they go out and look is widespread in the horses. And so I would suggest that if you're not going to start with the data and work back toward the problem, you start with the problem. And I mean, it's not every year, it's most years, but not every year. So I mean, you need to be out there collecting insects and looking for the virus in the insect traps. You know, you need to be out there testing animals and seeing which ones are coming positive. And I think the way to sell it to a Ministry of Health is that you probably can avoid the cases, or most of the human cases. You can control the outbreak in the horses, and there is a vaccine.
But that's exactly the kind of data is there, but data is only useful if there's a way that we're going to use the data. So if you just constantly collect data, but for your example, that's like, because it's a communication tool, but now the ministry can actually act on that data. That data is now useful. Otherwise, we're just kind of creating these, like, a lot of data, but the utility of it is something that sometimes I get confused with. So I mean, that's a great example of how data could communicate and inform resource allocation in the end.
But again, it's still a fight between the Ministry of Health and the Ministry of Agriculture, and then, you know, I don't know, universities who have to go out and monitor, you know, mosquito traps.
So Mark, I really like listening to all your questions, and I liked your call out to environmental health laboratories needing more resources. But one of the things when we talk about all this data, we collect, and like you said, we all want to share, but where's the repository for the data? I mean, who holds it? And if you've got to share it, where do you share it to? And who's gonna help analyze it? Any questions or any answers on that?
No, I mean, theoretically, and this is where WHO is trying to do WHONET and others, particularly in AMR, you know, kind of putting some context to it. But as many of you in the space, sharing data outside of borders can be quite challenging. I had to give a briefing to someone who was from Ministry of Health in a country that would do some work, and he just wanted to make the point that we don't touch their data as part of our work. And he said, what would it be like, and this is an example, he said, what would it be like if we came and said, I want your data from the US? How would you feel? I'm not gonna tell you how we're gonna use it. We just want your health data. It was a point that, you know, there's definitely sensitivity for sharing data, particularly across borders, aggregating, and sometimes in many areas, having all that data available can actually hit their tourism, their economic growth, and they don't want to share it. You know, there's a stigma that sometimes comes with data sharing. And these are the cultural barriers. I don't want to say that's not possible, but if we just kind of pretend it's not happening and don't address it and try to figure out how do you build that trust, I'm not an anthropologist, but to me, I feel that's the role that a lot of, I feel like there needs to be strengthened, in addition to environmental labs, but also the anthropological like implementation science of a lot of these programs.
I would just add a couple of points. One is with regards to why you collect the data. Data are useful for certain things and for certain purposes, but if you don't know what the data are going to be used for or what the purpose is, then maybe the data aren't that useful and they shouldn't be collected. Going back to the scenario, what is a disease agent? Each of the different disease agents has its own ecology, if you will.
Yeah.
And so and there are certain expertise that exists in countries because they work with that. They know how that disease affects the animal population and how it spills over the human population. There's sensitivities, but those are all specific to the organism. I'm thinking of some of the classical veterinary ones like tuberculosis and brucellosis and so many others. It can go on and on. I think the other examples are excellent as well, but there's a lot of expertise out there. Those people are useful as consultants. Do you really need that data? If that data would be useful in a specific problem that is impacting the animal health, the public health in a specific country. So just a couple of thoughts there.
Well, definitely. And what other data is needed? Like one data point's never going to give enough. So particularly in public health epidemiology, you need epidemiological data. You need a lot of other things to provide for it. So And then how do you mix it all together in a meaningful way is important stuff.
Getting to the point of sharing data, if the data has a specific purpose, then that's all well and good. And for veterinary diseases, of course, countries do report their animal disease status with regards to specific pathogens.
Yeah.
So those data are available to the OIE. At least some level of information is available. Is the disease prevalent? Does it even exist in certain countries? And it may not due to ecological reasons or particularly because of programs that are aimed at controlling and eradicating disease agents.
Yeah.
So that type of reporting does exist. Those data are pretty transparent.
Any other questions or comments or answers for Mark?
Yes, answers.
No pressure.
One more question from 30,000 feet. In a sense, there does exist something called the International Health Regulations. And the International Health Regulations cover both the OIE, PBS, and also the World Health Organization's elements of capacity building. And we have seen the use of this mechanism in the Eastern Congo, where it was declared a public health emergency of international concern. My question really is whether microbiologists have ever looked closely at the IHR as an entry point to be able to make the case that you are essential to a successful program.
In fact, Anna Payton probably hits her head on the wall every day, kind of representing the microbiology sector, and that we look at a lot of these indicators that are out there, and there's really nothing looking at laboratory performance and the role of the laboratory in these. And we're kind of surprised. I mean, Anna could probably speak more to it, but we're kind of surprised in a lot of these like JEE indexes and a lot of these other kind of readiness indexes that the laboratory is really, and if there is an indicator in it, it's probably an inappropriate one. So maybe like turnaround time. That's not really, or one indicator that she has is like, how many tests would these have available at one point when you go in there? Not really looking at the system. So Anna, that's her daily job, is trying to figure out how we can kind of get the laboratory indicators more within context of these larger indicators, but really strengthen them and have them meaningful. But Anna,
I think some of the problem is also that people are looking at like a 30,000 foot level, they're looking at really important things there, but then when you go down, I have not yet been to one lab where there's running water, which is pretty well not one.
but that's not an indicator.
You gotta talk about infrastructure. We're talking about microbiology labs too, so.
Yeah.
I mean, everyone here is well versed in, those buckets that they collect the water in and contaminated. I mean, it's just you think about that, it just snowballs. But yeah, there's big things like a lot of the labs, they have one competent person. That person leaves the lab, the whole thing goes back 15 steps. So we have a major workforce problem, but Mark can tell you all these things.
Yeah, but for us at the society, we don't want to just kind of put our heads in this. So we're really trying to think creatively, and this is something that Anna's really kind of focused on, is how do we start getting these indicators in there that we think are meaningful for a functioning lab? And how do we start having that conversation representing the microbiology field into the larger conversations of the bigger picture of preparedness and readiness? Because the laboratory for us, that's your detection point. But it doesn't operate in isolation, and that's something that she's looking from both health systems delivery, but as well as kind of public health, disease kind of surveillance. It's something that, I don't want to say, oh, we're kind of stuck. It's actually something that we feel as a mission as a society that we need to advocate for, as well as be smart and try to demonstrate that we can come up with good indicators.
Have you looked at the OIE PBS for veterinary infrastructures?
Nope, I have not.
Because
This is perfect.
I could be mistaken, but I think they really dig down into the veterinary laboratory infrastructures and their assessments when they go into countries and do assessments.
Yeah, no, there's a lot of great assessments. There's tons of great assessments, but no one has ever taken. In fact, the JEE has a whole way of assessing, but when they actually get down to standardizing, because we have problems with things that you probably accept as standard, like EQA. I mean, in actuality, when you're doing that in the labs, it's one person, there's no standard process, the vendors are not great. I've seen the data, it's not good. So, it's remarkable when you really drill down into it. There's really very few standardized indicators for the lab like there are for the health sector. I come out of maternal child survival, so there's some, I think that's probably where I'm comparing, and those indicators have been established and everyone's got those indicator definition sheet, there's rules about how we measure things, there's validated surveys. And so there's just a tremendous amount, I think, that can be done probably to help us collect better data so that our measurement's accurate. But the question is, what do we measure, like Mark's saying? But I would love to see that tool, so I will get your contact information after this.
This is the big question mark that Anna has, and I think we need a partner. And ASM can't do it alone, and then we're looking for other thought leaders just to figure out, like, even if these types of references are very helpful for us. Anna's probably one of the few staff members that we send to the library all the time, and she comes back with that sad face. So the more that you guys as practicing professionals can share with us, the more, obviously for us it's a shared good, but microbiology is one small picture of it, and if we could collaborate and figure out how to do it together, that's something that we feel it's a society mission in our role.
Any final thoughts and questions? All right, please. Thank you again.
Thank you, everyone.
I'm going to make a few announcements before you guys head out. If you haven't paid or signed in, please come see me after. Thank you to the Lyme Health Commission and American Society of Microbiology for allowing us to be here and allowing those on the webinar to be present with us. So thank you to them. And it looks like for this springtime, we will be meeting on the second Thursday of the month. So we hope to see you guys again soon. And we'll be reaching out with more notifications. And the Smithsonian Museum of Natural History has 2 volunteer opportunities. You can volunteer out the Outbreak exhibit. So I know that there's volunteers here that might be willing to speak on their experience. So definitely check that out. Or the Expert is In opportunity, which is a lower volunteer commitment opportunity, is still available as well. So they reached out to have me share that with you guys. And if you're interested, please let me know. I can connect you with the right people. So thank you for coming. And it's so great to see everyone. Hope you guys get home safe and stay warm. And thank you again, Dr. Lynn, for your time.